I'm Dr. Mark Lorenzato. This is one of two videos on narcotics use. It's the longer of two videos. Narcotics are particularly beneficial for both acute pain management and sometimes for chronic pain management. They do have the major complications of habituation or addiction, a tendency to tolerance, meaning that as they're used over time, it is important to use a higher dose to get the same effect. And they can cause constipation as one of the greatest problems with them. They also limit growth and perhaps limit emotional growth when in long-term use. They are divided in schedules 2 through 5, which roughly correlate with their effectiveness at management of pain, although there is some crossover where lower schedules or higher schedule numbers can actually be more effective than lower schedule numbers sometimes. In the clinic, I usually prescribe Schedule 3 narcotics, which is hydrocodone with acetaminophen or codeine with acetaminophen or buprenorphine combinations. Occasionally, I write for Schedule 2, which include oxycodone or oxycodone with acetaminophen. The propoxyphene sometimes is more effective for some individuals than hydrocodone or oxycodone, although it is a Schedule 4 drug. Common side effects of narcotics include nausea and nausea vomiting secondary to biliary or bile canal spasm. Constipation is probably the greatest problem for most people. This can induce a paralytic ileus or stoppage of the gut for contracting, which can end up causing a rupture of the intestine. It is a very serious and real complication of narcotic use. Itchiness, drowsiness, respiratory depression with excessive amount or if there is an impaired clearance of the narcotics. Dry membranes and urinary retentions are just about always experienced. Impaired alertness when the dosage is substantial to cause analgesia is common. And there can be circulatory compromise at higher doses. Confusion is not uncommon, particularly in the elderly or where people have an inability to break down the medication and clear it from their system. Abnormal heart rhythms can be obviously a very serious complication with some of the narcotics. Amongst the common problems besides the habituation and the constipation, symptoms of withdrawal can be very intense and difficult. They include cravings, chills, cognitive impairment, diarrhea, abdominal pain, general pain, headache, anxiety, and sweatiness. All things sort of the reverse of what the drug does. Exercising while under the influence can cause significant mechanical damage to tissue. Sometimes I have patients who use these medications to let them work against arthritic pain, which will potentially could damage their joints even more. There are major subtypes of receptors for narcotics in specific areas in the brain. Of these, the mu receptor is the most significant for pain management or analgesia. The other receptors do contribute to the balance of effects, including a tendency to addiction and the euphoria and dysphoric effects of these medications. It is now, in this time in history, possible to know an individual's DNA sequence and with this understand their SNPs, or single nucleotide polymorphisms, that make them unique. These SNPs correlate either with direct changes in amino acid sequences of protein or in genetic alterations that correlate with these changes. Either way, a SNP may be identified as something that will cause a morphine receptor to be more potent or less potent. At this time, the OPEM1 A118G SNP is known to code for an enhanced effect of morphine for those individuals that have this receptor. It is clear that we do not all have our DNA SNP patterns understood, but as things progress, we will be able to target better which medications work. The mu opioid receptor, as I said, is the most predominant of the analgesic affecting receptors. The mu has 3 common variants that are well characterized, the mu1, mu2, and mu3. The mu3 is the site of the alkaloid opioid medications, including morphine, oxycodone, hydrocodone, etc. Those medications, the opioid alkaloids, affect other receptors to lesser degrees. The delta receptors, although they have some play in analgesia, also are the target of the noxious stimuli. The enkephalins are pentapeptide, 5 amino acid long molecules, similar to other uh, molecules that affect the narcotic receptors in the brain. And in the case of the enkephalins, they tend to be activated with nauseous stimuli. When the delta receptors are highly stimulated, there is respiratory depression. This can, of course, lead to death if it's overstimulation. The kappa receptors are characterized under kappa 1, kappa 2, and kappa 3. They are the primary binding site for the dysnorphin opioid peptides. Treating the side effects of opioids and narcotics is extremely important, particularly constipation. The nausea can be managed with hydroxyzine, which is an antiemetic, anti-nausea medicine that I frequently write. Ondansetron is also effective. It has been used in chemotherapy because it is even has a better anti-nausea effect, although it is more expensive. Diphenhydramine is over the counter. It is also known as Benadryl. And ginger. These all can be used to treat the nausea of narcotics, and an individual may take these before 45 minutes or an hour before they ingest any narcotics to prevent the nausea that comes with the narcotics. Constipation, the best thing to do is to increase water intake and a reasonably good amount of soluble fiber, which was found commonly in oatmeal and beans. Stool softeners, including colace, are appropriate. Other measures may be taken. There is another video on constipation should this be an issue. To manage the sedation, caffeine or amphetamine perhaps might be used, and other medications can be used. So the common use of narcotics is for short-term management of cough and acute pain. Surgery or surgical procedures to prevent the response for pain will be treated with narcotics. Some chronic pain syndromes, narcotics is the best option. In the case of somebody with diarrhea, sometimes I'll prescribe a narcotic elixir because it slows the intestinal contraction and it works to reverse the diarrhea. It can be used as an adjunct in a stimulatory state. For example, if somebody is bipolar and they cannot sleep, they're awake for several days, sometimes narcotic will suppress their stimulation enough that they can get good sleep. So a short-term plan, I might write from hydrocodone with acetaminophen. I like to write it as Lortab elixir, but clearly it's in a generic form. It comes in the doses that I show here. As an adjunct, it's not uncommon to write some hydroxyzine for nausea. If not, a person can get over-the-counter diphenhydramine at 25 milligrams, taking 1 or 2 every 4 hours as needed for nausea. Instead of hydrocodone and acetaminophen in individuals who have in the past tolerated well promethazine and codeine, as an elixir, I will write that. Otherwise, less people tolerate well codeine than hydrocodone, so I tend to initially opt to the hydrocodone. Very good. That was a long talk. We'll make it succinct in the other version.